Dr. Kanwar, can you listen to us?
Yeah, of course I can.
Yeah, so we are waiting for you are the one who's going to tell us what does the guideline say, how to manage such patients, and before I, allude on what we did.
Divya has given quite a great description of what in such a situation you would do. The smart thing was probably to pick the case up as a pulmonary embolism rather early, I believe. Though they did look at the toxicology screen, which probably was the right thing to do in the beginning, in considering the fact that the patient is a young boy, and unless he has a very good reason to have a pulmonary embolism, why should he have a massive pulmonary embolism? I suppose there was a history of travel. Divya, can you hear
Yes,
me?
sir. There was a
Okay.
history of travel, sir.
History of travel was there. And did you check the protein CS and cardiolipin antibodies, homocysteine level, lupus anticoagulants and stuff? Because
That
normally
was
you
sent
won't
from the
expect it.
emergency, sir.
Yeah, okay. Because uh, I think you got the picture clear because the patient was continuing to be in hypotension and for no reason, and there was no infection. And what would be the reason? There wouldn't be hypovolemia. You probably would have given enough fluids. If the patient comes in hypotension, the first thing you do in the ED is to give plenty of fluids. If it doesn't build up, an echo is called for an echo, would probably give you a very clear picture in somebody. Okay, all right.
Yes.
So in such a situation, my overriding concern would be what is the status of the RV? Because if there is a massive or submassive pulmonary embolism, it is the RV which is going to decide how aggressive you are going to be in the management plan. Of course, you will thrombolize immediately. There is no, you will give anticoagulants immediately, and whether you will thrombolize or even go ahead with a, you know, a thrombectomy in case there is a massive pulmonary embolism, because you would not go for a VQ scan in this situation. You are you probably in the pulmonary in the echocardiogram we have seen the IVC moving paradoxically on the other side to the leftward side, and the things that happen is not only the uh, problem with the pressure, there is also infiltration of the right ventricle with the inflammatory cells, which are probably triggered by serotonin and thromboxane A. And not only that, there is a hypoxia developing, and that further aggravates the problem. And then once the cardiac output is reduced, the left ventricular preload is reduced. The RV output is reduced. Left ventricular preload is reduced. Your cardiac output is reduced. The return is reduced. So the the right ventricle and the coronary perfusion gets decreased. So the supply to the right ventricle goes down. All this put together put such a tremendous burden on the right ventricle that a CT, a PA, urgently in such a situation would help you decide, is it a saddle embolus, a large embolus? Because in such a situation, you're not expecting small pulmonary blocks, in the periphery. You would probably be seeing something massive sitting in the main pulmonary arteries, not only on one side, maybe on both the sides. And you got to have a circulatory block of at least 30 to 50% to cause any submassive changes, but more than 50% of that circulatory block to cause a massive situation with a shock. Um, uh, Once we do a CT pulmonary angio, I think the CN becomes very critical. And in this case, I believe the I don't know how many hours elapsed from the time that the patient came in and from the time that the diagnosis was made to the point that Dr. Khanna, you did thrombectomy, but the results were absolutely rewarding. The mortality risk in such situations is very high. And can I show my slides, please? Well, D dimer,
Can't see
I was
it.
told by Divya that the D dimer was pretty high in this case, something like 3,000 to 4,000 microgram range. So
Yes, sir.
if it is positive, then you certainly your possibility of a PE is enhanced a lot, and you go straight away for CTPA. But suppose this patient had a low D dimer, then you probably would be thinking of something else happening which you don't know, whether he's bleeding somewhere in the gut, whether something else is happening, or is a hypovolemic which shock which is still obscure. And certainly a pancreatitis wouldn't happen, and it wouldn't cause leakage in the gut. So there is something which is happening. And uh, if there is a clinical high probability, and the description has been given by Divya very well, if there is a high probability of PE clinically, then you would straight away go for CTPA. In that case, you wouldn't wait for the D dimer result to come and waste that much time, which is not fair. Once PE is confirmed, obviously you would go for the treatment as planned. And if there is no PE, then obviously you will investigate further. Now,
Okay, so now,
patient, yeah. Sorry.
go ahead. I thought you were finished, so we can start with what we did.
Okay, if there is a suspected PA with hemodynamic instability, then obviously bedside transthoracic echo would help you know what is the RV status. And if there is normal RV, then obviously you would be looking for some other causes. But if there is an RV dysfunction, then these are the guidelines which have been proposed, 2019 guidelines. So I think I mean we just follow these cases with the guidelines only, and whether to hospitalize the patient or discharge the patient home if there is no evidence of pulmonary embolism, patient is hemodynamically stable, and he can look after himself at home, then only you think of discharge of such patient. But if the patient is stable, having pulmonary embolism, stable, but cannot look after himself at home, and or there are other reasons, comorbidities for hospitalization, you would still keep the patient in the hospital. And but if the patient is very sick, BP is low, then you will straight away go for reperfusion as a very important option. We have already talked about the RV dilatation, tricuspid valve insufficiency, and the right ventricular tension that develops, and neurohormonal activation, as said, serotonin and thromboxane A2 are important in that, which lead to myocardial inflammation, and the right ventricular oxygen demand is increased because there is so many factors which are running around. And in 1/3 of the cases, there is a right to left shunt also. That's why in some cases they have even seen stroke happening in these cases because of the opening of the foramen ovale. And right ventricular ischemia, hypoxic injury, there is a hypoxia already happening, and that reduces the RV contractility, and RV output goes down, LV preload goes down, cardiac output goes down. As I said earlier, that this is a vicious cycle which we have to break, and the only way you can do is to break the thrombus and do thrombectomy in a very severe, very sick, hypotensive, shock patient due to pulmonary embolism. Thank you.
Okay, Dr. Kanwar, that was a good overview of what should be done. And let us see what we did. Let me just go to the screen sharing.